Good evening. Let me start another topic. Smoking and periodontium. Smoking is a highly prevalent worldwide and can be considered as an epidemic in both developed and developing nations worldwide. It is estimated that there are more than 1.3 billion smokers around the world. Around 1 billion men and 300 million women. So it's a worldwide problem, and it is one of the major risk factors in periodontitis, affecting the prevalence, extent, and severity of the disease. Actually, smoking, according to public or according to the individuals, they say it is a pleasure. They say it is a stress reliever. Some consider it as a procedure related with alcoholic drinks. And altogether, I will say many persons are very much addicted. Means blood has got a very strong thirst regarding smoking rather than alcohol. So the smokers or the smoking materials been classified into BDs in ancient times, or maybe nowadays also. Coolie class used to smoke BDs, cigarettes, cigars, then hookah, pipes, etc., which is smoke products, and smokeless like chewing tobacco, sniffs, zarda, betel quid with tobacco, gutka, pan masala, khaim, and mawa. This is all available in strips, sticks, lozenges, and even e-cigarettes. The English word tobacco originates from the Spanish and Portuguese word tabaco. It is a product prepared from the leaves of the tobacco plant by curing them. Any form of tobacco, either in a smoke form or a smokeless form, is dangerous. BD is in a crude form, but cigarettes are in a refined form. It all can cause cancers and acute myeloid leukemia. It also causes heart diseases and strokes. Most cigars are made up of a single type of air cured or dry tobacco. So these forms are in a larger size and a smaller size, but all has got the same effect. Hookah is a pipe used to smoke. Shisha, a combination of tobacco and fruit or vegetables that is heated, and the smoke is filtered through water. Then comes pipes. It's a sign of dignity. Again, the effects are same. Some use reverse smoking, reverse Chota mechanism, usually prevail in Andhra Pradesh, and it is again causes burn and oral cancer. Smokeless tobacco, again chewing tobacco, nicotine as an addictive material and dependent, and it can also cause oral carcinoma or submucous fibrosis, a precancerous condition. Snuffs usually use tobacco snuffed through the nose, leading to maxillary sinus carcinomas, and even it can cause carcinoma of the oropharynx. Then usual tobacco betel nut chewing. It is one of the commonmost things usually find in India. Then again, it is a culprit because it's been incorporated with tobacco. So again, it has got a problem with the same effect in case of smoke. There are dissolved tobaccos also, and electronic cigars or e-cigarette, which has got a nicotine delivery system, but all has got a deleterious effect. According to WHO, smoke contains 4,000 noxious chemicals and comprises a gaseous phase and a solid phase. Gaseous phase contains carbon monoxide, ammonia, formaldehyde, hydrogen cyanide, and 60 other known and unknown products. The main solid phase is nicotine, which is tar, benzene, and benzopyrene. All are dangerous products. Nicotine accelerates the release of neurotransmitter dopamine in nucleus and accumbens of brain. Nicotine retards growth of gingival fibroblast, reduces fibronectin and collagen, increasing collagen breakdown, and it also increases blood pressure, increase heart rate, increase respiratory rate, peripheral vasoconstriction, psychological dependence, and again physical dependency or craving. Smoking leaves an unseen scar. It fills your insides with toxins and tar. That's why the government has took great measures to prevent smoking. Theaters and in public places, statutory warnings are there. In all movies, they are just giving. And everywhere police is being aware of to both passive smoking and also the person who smokes has been legally arrested. Effects of carbon monoxide. Decreases the oxygen content of blood, thereby increasing the load of the heart. Carcinogenic irritants damage the lungs, causing narrowing of the bronchioles and cilia. Main cause of stains on the teeth and even the hands. Benzene, which is a solvent used in fuel manufacturers. Formaldehyde, highly poisonous liquid used for preserving dead bodies. Ammonia, chemically cleaning fluid used to increase delivery of nicotine. Hydrogen cyanide, highly poisonous gas used in the manufactures of plastics. Dyes, pesticides, fumigant to kill rats. There are current smokers having a smoke greater than 100 cigarettes in their lifetime. Former smokers have smoked more than 100 cigarettes in their lifetime and currently not using it. Non-smokers have not smoked in their lifetime and do not currently smoke also. Heavy smokers, 25 or more cigarettes per day. Moderate smokers, 15 to 24 cigarettes per day. And light smokers, 14 or fewer cigarettes per day. Both active and passive smokers. Effects of smoking, basically on etiology and pathogens of periodontal disease. Smoking is a major risk factor affecting the prevalence, extent, and severity of the disease. In addition, smoking adversely impacts the clinical outcome of non-surgical and surgical therapy and long-term success of the implant placement. So, there are comparative studies. There is deeper probing depth and a larger number of deep pockets, and also more attachment loss, including more gingival recession, more alveolar bone loss, and more tooth loss. Ultimately, the periodontium is suffering. So, smoking poor general health, poor plaque control, healing impaired, reduced biological defense, poor systemic health, and more pathogenic periodontal flora, leading to periodontal destruction. Mechanism of toxicity: increased bacterial adhesion to epithelial cells, decreases antibody protection, immunosuppressive effect, vascular alterations, physical subgingival effect, nicotine on root surfaces. The effect of smoking on periodontal pathogens show that smokers had a higher prevalence of bacterial species related to periodontal disease compared to non-smokers. Such organisms are P. gingivalis, Agrigobacter actinomycetin intermittens, Bacteroides forsythus, Privateland remedia, and Fusobacterium nucleatum, all involved in periodontal disease. The impact of smoking: increased colonization of shallow sites, that is pocket depth less than 4 mm, more prevalent in maxilla than in the mandible, and significantly higher levels of T. forsythus, 2 to 3 times more, and greater chance of periodontal pathogens remaining in the pocket after periodontal therapy. And there is no effect on the rate of plaque accumulation. Now, another important factor is smoking and host response. Literally, smoking decreases the salivary secretion, that is IgA, which is an immunocomponent, and serum IgG specifically reduces Ig2. Phagocytosis and killing of bacteria have been affected. Proliferation capacity of T and B lymphocytes has been reduced because the diminished production of such protective antibodies will cause an alteration in the host defense. Smoking may modify the production of pro-inflammatory cytokines, leading to which are considered as the key regulators of host response to microbial challenge. Alterations in neutrophil number or function, chemotaxis, directed locomotion from the bloodstream to the site of the infection, phagocytosis, and killing using oxidative and non-oxidative mechanism is being altered, and also increase in the release of tissue destructive enzymes. Changes in the immunoinflammatory response in smokers. The increased prevalence and severity of periodontal disease associated with smoking suggests host-bacteria interactions altered in chronic periodontitis leads to extensive periodontal breakdown. This imbalance between bacterial challenge and host response may be caused by changes in composition of the subgingival flora or subgingival plaque, increase in numbers and virulence of pathogenic organisms, host response to the bacteria challenge, or a combination or both. Effect of smoking on calculus formation. Increases in supragingival calculus, usually more common in pipe smokers, leads to increase in salivary flow and increases in calcium and organic products. Effect of smoking on gingival blood flow. Alterations in the gingival vasculature, which includes decreased vascular density, lumen area of gingival vessels and epithelial thickness is reduced. Percentage of small-sized blood vessels was higher. Decreased tissue oxygen tension leading to infection. The typical clinical appearance of a smoker's gingival tissue is which demonstrates relatively low levels of marginal inflammation and more of a fibrotic appearance with little edema and decreased blood flow. Despite the clinical appearance of the gingival tissue, the patient has deep pockets, advanced attachment loss, and bone loss. Effect of smoking on GCF. Disease sites in smokers showed significantly lower total GCF volume. Protease inhibitory molecules and increased destruction action of certain proteases, especially elastase, increased levels of tumor necrosis factor. So all these findings show the effect of smoking on GCF, which in turn relate to the defense mechanism of the body. That means in that decrease in gingival blood vessels lead to increased inflammation, decrease in GCF and bleeding on probing, decrease in subgingival temperature, and also increased time need to recover from local anesthesia. Again, effect of smoking on fibroblasts. Smoking alters the cell viability, cell migration, and differentiation. And also, nicotine inhibit the production of fibronectin and type 1 collagen, increases collagenase activity by increasing the production of cytokines by fibroblast. Dose response relationship of smoking. A strong dose response relationship exists between cigarette smoking and ischemic stroke, usually seen in young adults. Increase in probing depth and attachment loss in maxillary lingual area, and mandibular anterior area, suggesting a local effect of smoking. Young adults between the age of 19 to 30 years who smoke are 3.8 times more likely to have periodontitis than non-smokers. It's also reported an associated incidence of caries incidence, plaque development, calculus formation, and periodontal disease. Its effect on older patients causes greater pocket frequency, probing depth resulting in bone loss, pocket formation, premature tooth loss. Another important factor is passive smoking. The main victims are children because they are exposed to second-hand smokers, either mother or father, or anybody related to their house. Have more ear infections, have more respiratory infections, have more asthmatic attacks, and they miss their good old school days because of these type of infections. And increases the salivary levels, albumin, aspartase, and lactoferrin. And in young adults, there is greater attachment loss. In case of therapy, there is response of smoking on periodontal therapy. Non-surgical therapy, I'll tell you, by scaling and root planing, clinical attachment, which is less pronounced. The clinical attachment levels improvement in smokers are 50% to 75% less in those of non-smokers. It can be concluded that smokers respond less well to non-surgical therapy than non-smokers. In case of surgical therapy and soft and hard tissue grafting, clinical attachment gain in non-smokers is 5.2 millimeter compared with smokers, which is very less, that is less than 2.4 mm. And higher plaque levels are also seen in case of smokers. Vertical bone gain in smokers range from 0.4 to 0.5 mm, whereas in non-smokers is demonstrated more than 0.9 to 3.7 millimeter improvement. And there is less root coverage compared to non-smokers. In case of implant therapy, this is a newer treatment line in dentistry. 8.9% of the implants placed in smokers failed to compare to 6% in individuals who had never smoked or had quit smoking. Negative impacts of smoking on implants placed in maxillary arches has been reported. The implant failures in grafted sites in smokers is 2.5 times greater than that of non-smokers. Thus, the long-term prognosis for smoker patients is poor for all modalities of periodontal therapy. That is the main problem of smoking. Antimicrobial therapy in smokers. Groups included scaling and root planing, either alone or in a conjunction with the application of 25% of tetracycline fibers, 2% minocycline gel, or 25% metronidazole gel were studied. Regardless the type of treatment, the change in the probing depth and attachment gain were greater in non-smokers subjects than smokers. Some of the lesions associated with tobacco in the oral cavities are smokers' melanosis. Because of the stain formation, many of the smokers brush vigorously, leading to severe stains and abrasions. Acute necrotizing ulcerative gingivitis or other periodontal conditions, burns and keratotic patches, nicotinic stomatitis, palatal erosions, leukoplakia, epithelial dysplasia, and squamous cell carcinoma ultimately. So altogether, if you take, this is a very alarming situation where oral submucous fibrosis, one of the main culprit leading to squamous cell carcinoma in the oral cavity. So, and oral leukoplakia. So, many consider smoking will reduce halitosis, but I'll tell you it increases halitosis because of the dehydration and also due to the lung infections or the respiratory problems. And there is dry socket in smokers. And respiratory system is very badly affected because of smoking. It also involves a cardiovascular system and central nervous system. And it has got a very adverse effect in pregnant women, sudden infant death, spontaneous abortion, ectopic pregnancy. There are a lot of problems in systemic diseases which aggravate periodontitis in smokers, smoking cessation, and periodontitis. Former smokers has less risk for periodontitis than current smokers, more risk than non-smokers. So I conclude this topic with approximately 90% of the poorly responding patients were smokers in periodontal therapy. So better option, it is clear that if you need a periodontal therapy to be success, you or either your patient has to quit smoking. This thorough education regarding smoking and repeated maintenance visits and counselings will be a success criteria for smokers. You can use other modalities of nicotine patches and counseling centers for smoking, and you can quit into some other methods. You can shift into some other methods by quitting smoking. So, as a dentist, it's our duty to educate the patient regarding this to get a better treatment modality regarding periodontitis or is systemic health. Thank you.